addressing some barriers within the scope of practice, and becoming familiar with different treatment options that's beneficial to both the disease state of obesity and diabetes. So diabesity is one of our new favorite terms. That was our Obesity Week theme last year or year before. So obesity was actually declared by AMA to be a chronic disease state in 2013. Which means it needs to be treated like any other chronic disease. It requires long-term treatment. You wouldn't start a patient on an antihypertensive, get them to goal, and then take them off the medication, correct? So we need to change our mindset and think about obesity in that same way. And we have now gotten to the point where 42% of our adult population in the US falls into the obese category. So that means a BMI of 30 or greater. And about 10% have diabetes. We know that even small changes in weight can affect the blood sugars as well. Next slide. So where to begin? Obesity and weight is a very difficult topic to address. It's one of the very few visible disease states, and oftentimes patients report that they are blamed for being obese. And so it does make them more likely to not seek medical care. And you have to start the conversation somewhere. It can be very uncomfortable, and a lot of times it's just avoided. But what we need to do is be open, approach the patient and say, yes, you're at a higher risk. This is where your weight falls. And treatment goals include improving your health, your quality of life, and your body weight and composition. And none of those treatment goals are very different than treating diabetes, right? So oftentimes you just want to have an open conversation, establish rapport, and not blame the patient. Be careful of your language, that sort of thing. One good place to start is always to refer to a diabetes education program or a registered dietitian for medical nutrition therapy. Weight management, not very often covered by insurance companies, but diabetes is pretty much going to be covered. So that's a good place to start for the patients. Next slide. Obesity is a complex disease. So again, a lot of times patients feel blamed. One thing that I hear over and over again in the bariatric population is that their PCP just tells them to eat less and move more. That's just a small component of the disease state. We know that there's a genetic factor. Our non-Hispanic Black population has the highest rate of obesity, followed by Hispanic, then non-Hispanic white, and then Asian population. So there is a genetic component. Something else to keep in the back of your mind as well is while our Asian population may have a lower incidence of obesity, they're at a higher risk of developing diabetes at a lower BMI. So if they're starting to get into that overweight category, you really want to be proactive because and checking those blood sugars to make sure that diabetes isn't developing. Environmental. I know particularly here in Houston, and I definitely know in Baton Rouge, we're big commuter cities, right? It's very rare that people live in an area where they are easily able to walk or bike to work, to the grocery store, whatever the case may be. And so that definitely is a factor. There is a behavioral component. So, as we talked about with Kristen's case study, that's a very important foundational part of the treatment plan. There may be other things going on from a metabolic or endocrine perspective. Hormones can be a beast and really, really contribute to weight gain, as well as other medical issues or medications. So we'll actually look at that in a minute as far as what types of medications in particular actually contribute to weight gain. And then socioeconomic status. it is not super affordable to eat well. And so that too contributes. So this is a great algorithm from OMA. They have a ton of really good free resources. And so it kind of goes through the treatment of obesity as a disease. So what I wanted to look at really is at the bottom. So nutritional intervention, physical activity, behavioral therapy, pharmacotherapy, and then bariatric procedures. Again, is this really any different from the treatment of diabetes? It's very, very similar. So some very common obesogenic medications are listed here. Oftentimes our patients with diabetes have comorbidities of depression, high blood pressure, hormonal imbalances. And so there are certain medications that may be contributing. Now, of course, this needs to be individualized. The risk of stopping or changing these medications may far outweigh the benefit of some weight loss. So that needs to be discussed and looked at with every single patient. Some SSRIs, as we mentioned earlier, over time do contribute to weight gain. Tricyclic antidepressants, beta blockers. I will tell you one thing that I see on most of our inpatient med list is metoprolol, and that is a major one that contributes. And getting those hormones in line. If patients are on steroids long-term, that's something that we may want to look at. Okay, can we do some sort of anti-inflammatories instead? And with beta blockers, could we do an ACE inhibitor? That sort of thing. And bupropion, the Wellbutrin, is a good option sometimes for antidepressants or combination, especially some of the newer drugs like the SNRIs too. As far as diabetes-specific medications, basal insulin does contribute to some weight gain, sulfonylureas, and TZDs as well. Some weight-friendly diabetes medications, on the other hand, glucophage, which we know is always our first step in the treatment of diabetes, liraglutide, GLP-1 agonists, SGLT2 inhibitors, and pramlintide. So those may be options to explore with your patients to change over to or incorporate. And actually, this slide here is from ADA. And I know there's a lot going on right here, but what I wanted to highlight is in the red box, where there is an entire category specific to optimizing blood sugar control while considering weight. And so it starts you out with looking at, in addition to metformin, GLP-1, SGLT2, and then building from there on combinations and adding on. Now, diving further into actual treatment of the obesity itself, there are quite a few medications now that are FDA approved for weight loss. You can see these listed here. And one thing to note, which I had recommended for the binge eating, Vyvanse is one that is labeled for binge eating disorder, which is pretty common in our patient population. And so that may be something to explore to help manage their intake. And then off-label, as we discussed as well, a lot of these medications, it's very difficult to get covered by insurance. And they're very, very, very expensive, especially the injectables. It's nothing for those to be $1,000, $1,200 a month, which is obviously ideal for very little of our population. So some off-label things that we can do. Metformin has been shown to show moderate weight loss. Phentermine is probably the most affordable option on here. However, it is only labeled for 12 weeks. And again, this is a chronic disease process, so we can't just stop it at 12 weeks. So off-label, you could continue that, or the combinations like the topiramate, bupropion, and naltrexone. as long as the patient is agreeable to this and understands the need for follow-up. And the most effective treatment for both weight and type 2 diabetes is bariatric and metabolic surgery. So I'm kind of going to leave y'all a little bit on a cliffhanger because I'll see y'all back in a couple of weeks where we'll really focus on those types of procedures. And so here I have some resources, and one that I realized I forgot to put on here was the Obesity Action Coalition. This is also another great resource that you can request materials from, and they'll send you all kinds of free handouts for patients as well, and resources. References and questions. Yes, that's my dog.
Thank you so much, Emily.